Hello everyone, welcome in this new video which is based on infections in diabetes. It is seen that the infection, any kind of infection, impairs the glycemic control in any patient with diabetes, and this impaired glycemic control is due to increase in the insulin resistance, and this increase in the insulin resistance is due to the release of cytokines as well as by the other counter-regulatory hormones. This infection may be a precipitating factor for development of a severe metabolic complications of diabetes, which is known as ketoacidosis or diabetic ketoacidosis. It is seen that there is vicious cycle between the infection and hyperglycemia. It means whenever there will be infection in any patient with diabetes, it will further lead to impaired glycemic control. It means it will raise the blood sugar level, and whenever the blood sugar level is uncontrolled or there is impairment in the control of blood sugar level in any patient with diabetes, this will decrease the immunity in the person and it will ultimately lead to various infections in such patients. As we know that in any patient with diabetes there is immune system dysfunction, and that's why diabetes is considered as an immunocompromised state. And to develop this immunocompromised state, there are defects in various immunity system and the cells involved to produce such immunity system. Let's discuss first about the cellular innate immunity. For cellular innate immunity, the neutrophils and monocyte or macrophages are responsible, but in any patient with diabetes, it is seen that there is defect in neutrophil chemotaxis, adhesion and phagocytic function against any infection, which is a natural function of neutrophil against any infection. Apart from that, there is also defect in macrophage or monocyte induced chemotaxis and phagocytic infection function against any infectious agent. Apart from that, there is reduced production of reactive oxygen species, also known as ROS. Due to this reduced production of ROS, there is impaired killing of the pathogens. The second kind of immunity in our body is humoral innate immunity. For this, the T lymphocytes and monocyte macrophages are responsible. In any patient with diabetes, there is elevated levels of pro-inflammatory cytokines, and also there is reduced cytokine response to any stimulation or any infection. The third kind of immunity is cellular adaptive immunity, and this cellular adaptive immunity is produced by T lymphocytes. However, it is seen that in any patient with diabetes there is impaired proliferative response against any stimuli in diabetes, as well as there is impaired delayed hypersensitivity reaction against any infection, and because this delayed hypersensitivity reaction, patient is unable to recognize any kind of infection in his body taking place. The fourth kind of immunity is humoral adaptive immunity, and this is produced by the B lymphocytes and plasma cells. Usually it is seen that these cells are usually not affected in any patient with diabetes, and they show normal immunoglobulin response against any infection and vaccination. So finally, we can summarize that in any patient with diabetes, these three main mechanisms of against any infection are compromised. They are cellular innate immunity, the humoral innate immunity, and the cellular adaptive immunity. However, only humoral adaptive immunity is intact in any patient with diabetes. Now let's discuss the various predisposing factors for infection in any patient with diabetes. The first factor is peripheral vascular disease, which is very common complication in any patient with diabetes. The second predisposing factor is peripheral neuropathy. The third predisposing factor is chronic renal failure and dialysis. As we know that diabetic nephropathy is one of the common microvascular complication in any patient with diabetes, and due to this there is development of chronic kidney disease or end stage renal disease, in which the dialysis is the chronic requirement in any patient with diabetes, which predispose for the infection. The fourth common factor is urinary catheter and intravascular lines, which are the requirement for any patient with diabetes, kidney failure. All these factors are usually secondary factors. Now let's discuss few predisposing factors for infections in diabetes, and these are agent specific factors. The first agent in this diabetic infection is Candida albicans, which is a kind of fungal infections, and the Candida albicans in any environment of high glucose level, this stimulate the production of certain complement like proteins. These complement like proteins promotes the adhesion of such fungus Candida albicans to attachment at various vaginal and buccal epithelium, and ultimately results in the causation of infection as well as the flaring of such infection in any patient with diabetes. The second fungus is rhizopus. Second agent is rhizopus, and this rhizopus is seen to produce some enzyme known as ketone reductases, and this enzyme allows them to survive in such hyperglycemic condition, and this also allow or favors them to grow or to survive in such acidic environment of diabetic ketoacidosis, and ultimately all this lead to development of such infection and complications. So what are those common infections in diabetes about which we are talking about? The first common infection is urinary tract infection, also known as UTI, and this consists of infections at various parts of urogenital system. That's why it causes cystitis, the pyelonephritis, and renal and perinephric abscess. The second common infection is respiratory tract infection, also known as RTI. This consists of pneumonia caused by Staphylococcus aureus bacteria, the gram-negative bacteria, the lung abscesses due to infection, and the tuberculosis. The skin and soft tissue infections are also very common in diabetes. This consists of various surgical wound infections, the foot infections which causes the development of foot ulcers, about which we will discuss in detail in another presentation. The another common infection is abdominal infections, which leads to development of Salmonella enteritis, the Campylobacterial jejuni infection. The fifth common infection is eye infections, which causes development of stye, also known as hordeolum externum, and chalazion, also known as hordeolum internum. And the sixth common infection in diabetes is oral infections, which causes periodontitis. If you want to know further about this oral infections, common oral infection, periodontal diseases in diabetes, so for that you can follow this I button. If we are discussing about the infections in any patient with diabetes, so we must give emphasis to food infections, which are common initiating event which results in limb loss, and these foot infections are the one of the leading non-traumatic causes of amputations in any patient with diabetes, and about 60% of the lower limb, lower extremity amputations in any patient with diabetes are due to the infection in foot, also known as infected foot ulcers. These infected foot ulcers may be due to the various kind of bacteria. That's why these foot infections are usually termed as polymicrobial, which are consisting of aerobic gram-positive bacteria, the gram-negative organism or bacteria, and obligate anaerobic bacteria. Sometimes this diabetic foot infection can lead to a potential emergency, and it can suddenly change into some serious complication in any patient with diabetes within an hour. Now let's discuss the tuberculosis infection in any patient with diabetes. So it is seen that up to 40% of the patients who are having TB, they are also positive with diabetes. Discussing about the relative risk RR. So it is seen that the relative risk is about 3.11 in any patient with diabetes. It means any patient with diabetes have 3.11 times higher chances of developing TB as compared to those who is not having any diabetes. It is also seen from the various studies that about 5 to 30% of the patient with diabetes are having TB. There are few peculiarities of TB in any patient with diabetes. So it is seen that any patient with diabetes usually develop the pulmonary TB as compared to extrapulmonary TB, and in such patient with TB they show very less or delayed physical signs, and due to this there is delay in the diagnosis of such TB in any patient with diabetes. This TB is with extensive cessation and cavitation, and usually they are more likely to be having Schmitzum acid fast bacilli positive, and there is minimal pleural involvement in such TB. Usually the sputum smear clearance is delayed in such TB with diabetes. This delayed sputum smear clearance means that the smear positive pulmonary TB with a sputum sample that remains acid fast bacilli smear positive till the end of intensive phase of such TB. It is also seen that the treatment failure, relapse, reinfections are very common in any patient with diabetes who develops the TB also. Now discussing to the treatment of tuberculosis in any patient with diabetes. So insulin is the drug of choice in any patient with diabetes having TB. There are few advantages of insulin in any patient with TB, that it improves rapidly in glycemic level of any patient. It also helps in correcting the cachexia. Cachexia means the weakness and wasting of the body associated with TB. It also helps in better healing process. The oral antidiabetic drugs are found to be interactive with other anti-tuberculosis drugs, especially among these oral antidiabetic drugs. The rifampicin is found to be interactive between other drugs. That's why these oral antidiabetic drugs should only be used in mild hyperglycemia. Otherwise, insulin is the drug of choice. As we know that the isoniazid, which is a anti-tuberculosis drug, can cause peripheral neuropathy as well as it can worsen the peripheral neuropathy. For success of anti-tubercular therapy in any patient with diabetes, the tight glycemic control is must requirement. Now discussing to the association between the diabetes and HIV. Usually diabetes is not considered a risk factor for having HIV infection, for developing HIV infection. However, the people living with HIV and AIDS have higher chances to develop type 2 diabetes compared to those who are having no HIV infections. And it is found that the drugs are usually used to treat highly active antiretroviral therapy HAART for HIV and AIDS can predispose to development of diabetes. Among these drugs, the protease inhibitors and nucleoside reverse transcriptase inhibitors NRTIs are the commonest for causing developing diabetes in any person. These protease inhibitors includes the ritonavir, lopinavir, nalfenavir, etc. This nucleoside reverse transcriptase inhibitors include lamivudine, stavudine, amtricitabine, tenofovir, etc. This protease inhibitors affects the insulin secretion as well as the insulin sensitivity and causes the development of diabetes. The NRTIS drugs, they produce diabetes by affecting the insulin sensitivity as well as by causing lipodystrophy, the mitochondrial dysfunction, and the commonest drug among these NRTIs which leads to development of diabetes is stavudine. Apart from that, the other drugs which are used to treat the comorbidities in any patient with diabetes like pentamidine can also predispose to development of diabetes. It is seen that the incidence of iatrogenic diabetes in any patient with diabetes is very high. It approx 5.72 per 1000 person years of follow-up, and in this highly active antiretroviral therapy induced diabetes, the insulin is the drug of choice, insulin is the treatment of choice. Apart from the bacterial infection, the tuberculosis infection and the HIV infection, the diabetes is associated with various other rare infections which are malignant otitis externa, the rhinocerebral mucormycosis, emphysematous cholecystitis, emphysematous pyelonephritis, emphysematous cystitis, necrotizing fasciitis, and Fournier's gangrene. Now let's discuss about the malignant otitis externa. This malignant otitis externa is the infection of the external acoustic meatus, that is external ear, as well as the skull, and the infection usually consists of pseudomonal infections of this part, and this malignant otitis externa is usually common in any elderly patient having diabetes. The common clinical presentations are severe pain, the discharge from the external ear, and sometimes there are features of facial palsy if the facial nerve is also involved. The treatment for this malignant otitis externa is aggressive debridement of the infectious part and use of anti-pseudomonal antibiotics. Sometimes this infection can be high motility can be there in such infection if this infection is left untreated. Now coming to the another infection which is known as rhinocerebral mucormycosis. The rhinocerebral mucormycosis is the infection of the nasal cavity and orbit by some fungi known as Fcdia, Rhizopus and mucor, and this rhinocerebral mucormycosis is very common in debilitating patients, usually those who are having diabetic ketoacidosis, and the incidence of such rhinocerebral mucormycosis is found highly among the COVID-19 infectious persons, those who are treated with glucocorticoids. Such rhinocerebral mucormycosis patient, they present with fever, pain, the extraocular muscle palsy, proptosis, chemosis around the eye. Sometimes discharge may also be there from the nasal cavity in orbit, and sometimes these also show the features of facial palsy if there is involvement of facial nerve, seventh nerve. The characteristic feature of these rhinocerebral mucormycosis infections are presence of black eschar, usually over the nasal turbinates. The complications of rhinocerebral mucormycosis includes venous sinus thrombosis and brain abscess. Venous sinus thrombosis is the blood clotting in the major veins of the brain, and brain abscess means if there is infection of the brain and causation of the abscess. The treatment of rhinocerebral mucormycosis include surgery and use of some antifungal medications including the amphotericin B and socanazole. If this rhinocerebral infection is untreated, then it is highly mortal. High mortality is associated. The another common infection in any patient with diabetes is necrotizing fasciitis. This fasciitis means inflammation and pain of the fascia, and this fascia is usually a fibrous tissue usually found in the various organs, and the common sites of this necrotizing fasciitis are abdomen, the perineum and the extremities. This fasciitis is usually present with pain, the inflammation. It usually does not involve the skin and muscle. If these soft tissues are infected, so the common cause for these soft tissue infections are streptococci bacteria, staphylococci and anaerobic bacteria. The necrotizing fasciitis is divided into three categories based on the infectious agents. The type 1 is polymicrobial, which is infection by the multiple varieties of bacteria. The type 2 necrotizing fasciitis is the infection by the group A streptococci, and type 3 is the infection by the clostridial myonecrosis, which is also known as gas gangrene. This infection is usually diagnosed by the culture from the necrotic part of the lesions, and the treatment involves the debridement of the wound and surgery and by use of the broad spectrum antibiotics. Now discussing to the fungus gangrene. Usually fungus gangrene is a type of necrotizing fasciitis which usually involves the perineum, the scrotum and the penis. The common causative agent of this fungus gangrene are E. coli, bacteroides, Streptococcus bacteria, the Staphylococcus, Pseudomonas and Proteus. This fungus gangrene usually presents with scrotal pain, pain in the scrotum region, swelling in the scrotum. Sometimes it can flare up to develop this systemic toxicity also. There is sloughing off of the scrotal region, and there is due to this the shameful exposure of the testes and the spermatic cord. Coming to the treatment of this fungus gangrene, this involves the unroofing of the lesions, use of broad spectrum antibiotics. Sometimes orchiectomy, that is removal of the testes, is also needed, and the fungus gangrene is found to be highly mortal. Now discussing to the emphysematous pyelonephritis. This is the necrotizing infection of the renal parenchyma and surrounding tissues. Usually this emphysematous pyelonephritis is exclusively found in the patient with diabetes. Female preponderance is usually seen, more common in female as compared to the male. The causative agent are E. coli and Klebsiella. In this there is fermentation of glucose is found, and due to this gas is formed, and the diagnosis is made by the radiological demonstration of this gas. The management includes broad spectrum antibiotics, the percutaneous drainage of the pus, and sometimes nephrectomy, that is removal of kidney, is also needed. So what are the effects of such infections in diabetes? It is seen that for better glycemic control is deteriorated during this infection. If any patient is on insulin, so we need to increase the dose of insulin. If any patient is on oral anti-diabetic drugs, in such patient there is need to switch from oral anti-diabetic drugs to insulin. If the person is with severe hyperglycemia or unable to retain the oral feeds, then admission in the hospital may also be required. In case of severe infection, there is more chances to develop diabetic ketoacidosis, not only in type 1, which is usually common in type 1, but the diabetic ketoacidosis may also develop in type 2 diabetes mellitus. Now let's discuss about the vaccination recommendations in any patient with diabetes. Firstly, the pneumococcal vaccine. A 23-valent pneumococcal polysaccharide vaccine, PPSV23, is recommended to be given all the adults having diabetes but below the age of 64 years, and the booster dose of this pneumococcal infection to be given after the age of 65 years. But there should be at least a gap of 5 years between the first dose and the booster dose. Influenza vaccine should be given annually. Preferably a quadrivalent vaccine of influenza should be given, but live attenuated vaccine of influenza should be avoided. Coming to the hepatitis B, 2 or 3 doses of hepatitis B vaccine should be given to all the unvaccinated adults of age between 18 to 59 years. And if the age is more than 60 years and person is with diabetes and person is unvaccinated, then we need to administer the 3 doses of hepatitis B. Coming to the tetanus and diphtheria, all adults should be given tetanus and diphtheria vaccine at least once, and the booster dose of this tetanus and diphtheria should be given in every 10 years. Coming to the herpes zoster vaccine, it is recommended for the adults who are 50 years and above, and this should not be given to the severely immunocompromised individuals. Now we have come to the end of this video. If you have liked this video, please share with others. Thank you so much.